Awesome. I just wanted to thank everyone for being here tonight. My name is Sheridan, if you haven't met me before, and I wanted to plan this workshop in order to highlight like the programming and work and amazing work that researchers have done in this community. And the first half of the workshop, I wanted to show what programming currently exists in our community and also show current data that some LGBTQ community members may to highlight some of the needs of current LGBTQI folks in Texas. The second half of this workshop will be a discussion about how to grow and create more programming to reach more members of the community. I think the amazing thing to point out is the nonprofits and organizations that have been working in Austin and Texas have been doing so much to reach all of the people that they can, and there's always space to grow or grow programming in order to reach more members of the community. So I'm hoping that we can brainstorm other ideas of other programs that we could implement in Austin or in Texas or in the whole United States to see how we can help gender and sexually diverse folks. So I wanted to thank all the speakers again for being here. We have Dr. Philip Schnarrs, an associate professor of community-based participatory research in the Department of Population Health. He's an applied health researcher and expert in LGBTQ+ populations, specializing in sexual health, mental health, and substance use disorder. We have Priscilla Hale, who is an executive director of ALGO, a queer people of color organization since 2013. In 1998, she joined ALGO as a case manager for people with HIV/AIDS and advanced to the director of health programs, which led to the outreach, education, and case management programs at ALGO. She became one of ALGO's co-directors in 2006. Her earlier career began with the Travis and Williamson County Juvenile Services as a certified juvenile detention and probation officer. She's a lover and producer of cultural arts and has produced and programmed activist events since 2008 as part of her work at ALGO. She earned her master's degree in social work from Our Lady at the Lake University in San Antonio and her bachelor's degree in social work from St. Edward's University here in Austin. We have Dr. Marisol McDaniel. She's a postdoctoral research fellow at the Latino Research Institute. She has experience with planning, implementing, and evaluating healthy lifestyle interventions and managing e-health applications. Dr. McDaniel is interested in sustainable structural and digital interventions that promote food security. She aims to prevent and decrease the burden of chronic diseases for marginalized communities in Texas. And Mr. Ben Walker is the clinical director at Austin Sexual Health and Wellness Ashwell in Austin, Texas. Previously, Ben served as a senior policy advisor at the Center of Health Empowerment and executive director at Austin PrEP Access Project, now Kind Clinic, which is amazing. A passionate advocate for eliminating healthcare disparities and expanding harm reduction education and strategies. He's recently served as a chair of the board of Austin Harm Reduction Coalition. Ben received his bachelor's degree from Austin College and his master's from the LBJ School of Public Affairs at the University of Texas, Austin. Ben lives in Austin with his partner, Mike, and their dogs. And if Ben, you want to introduce your guest as well, I would love that whenever you're presenting. And then we're going to start off with Dr. Schnarrs presenting, and then we'll go from there. Thank you so much. If you want to take the floor, Dr. Schnarrs.
Oh, I didn't know if Ben wanted to introduce.
I was thinking whenever they present.
For sure. Okay, I will. I just have a quick presentation to go through. So let's see, share screen. Not the right one. Ooh. All right, so as everyone knows, I'm Philip Schnarrs. I am an associate professor of community-based participatory research at UT Austin Dome Medical School. And today I'm going to talk a little bit about a community-based participatory research project in San Antonio called Strengthening Colors of Pride. First, I'd like to acknowledge the co-leads on the project, who are Amy L. Stone and Robert Salcido Jr., as well as acknowledge the funder for the project, which was the Robert Wood Johnson Foundation, through their Interdisciplinary Research Leaders Program. Let me start my timer. So the overall project aim for Strengthening Colors of Pride was really to understand queer resilience, because there isn't a lot of literature about resilience among LGBTQ individuals. But what often happens when we study things, we set out to study one thing and we end up studying something else. And what we started studying was actually adverse childhood experiences, and I'll talk a little bit about that in the next couple slides. We used a frame of research called community-based participatory research, and this is different than traditional types of research in that you co-create knowledge with community members, and they're full collaborators within your research project, everything from conceptualization of the project through dissemination of those results. So we used a model called a community advisory board, and our community advisory board was comprised of 15 individuals from different types of organizations that were related to LGBTQ advocacy, sexual health, HIV prevention, as well as religious organizations, 2 council district members, as well as the mayor's office and the equity office. This project was 3 phases overall. The first was a screener phase, which was a short survey. It took about 15 minutes. And that was for, led into the next phase, which when we conducted 82 interviews, pretty equally distributed across race and ethnicity, as well as gender identity, which led into our phase 3, which was a citywide community assessment of LGBTQ people, where we were able to recruit about 1,800 respondents. In terms of dissemination, because we were using CBPR, we wanted to make sure that we weren't just publishing academic papers. And what we did, we do currently have 5 papers out and about another 5 or 6 under review. We also did several town halls in San Antonio, as well as what were called community gatherings, which were mini town halls that were run by members of our community advisory board. So they selected the topics, they built out what the program would look like, and then we supplied the data and presented that data, and then had a community discussion around the specific topic that the community members had identified. So one of the papers that I'm going to talk about today is from the journal. It was published in the Journal of Psychiatric Research, and it's looking at differences of adverse childhood experiences and the quality of mental and physical health among between transgender and cisgender sexual minorities. So as I said, we set out to study resilience, and what we ended up really looking at, in addition to resilience, was this concept of adverse childhood experiences. And what ACEs are, or for short, or ACEs, are 3 areas that we consider, which are abuse. That includes physical abuse, emotional abuse, as well as sexual abuse, neglect, both physical and emotional, and then what we also call household difficulties. So maybe a member of the household has a mental health issue or a substance use problem, or the child is witnessing violence in the home, or an individual may have attempted suicide, or there's been a divorce or death in the family. So why is this significant? Is because adverse childhood experiences, we know that as you increase the number of childhood experiences, adverse childhood experiences, you also increase the risk for early death, the risk for disease, the risk for poor health, and problematic health behaviors. And so we know that about 67% of the adult US population has experienced at least one ACE, and that if you experience 4 or more ACEs, you're at increased risk for things like substance use disorder, depressive symptom, depression, cardiac disease, type 2 diabetes. And if you experience 6 or more ACEs, it can shave about 20 years off the average life expectancy. Recent data shows us that about 16.7%, or about 1 in 6 individuals, has experienced 4 or more ACEs in the US adult population. And so why do we want to look at ACEs? Well, ACEs is a huge public health issue. And if we address early childhood adversity, that can also impact a myriad of health conditions, as well as risk behaviors, and also socioeconomic challenges. We know that individuals who experience significant ACEs are less likely to graduate from high school, have higher rates of unemployment, and are less likely to have insurance as well. So for this study, we're talking about data from the screener here. We used a really broad recruitment strategy. The first thing that you can see here is that we placed table toppers in businesses throughout San Antonio that were either run by LGBTQ individuals or were LGBTQ friendly, so that while they were waiting for their food, for example, they could take a short 15-minute survey. We also flyered at local, throughout the public library system, in colleges and universities, as well as other government spaces. And we also did some online recruitment. This meme here that you see, that pulls from the show Pose was created by some of our undergraduate research assistants for the project. And we also handed out palm cards that had a QSR code on the back at a lot of LGBTQ events over the summer, and also during the annual Pride event in San Antonio. Like I said, we're talking about the screener data here, and on that screener survey, we had 4 areas that we were really looking at, which were resilience, which is a brief resilience scale looking at how individuals believe themselves to be resilient. The ACEs measure, which is 10 items that you identify yes or no that you've experienced this thing, as well as quality of mental health and quality of physical health, ranging from very poor to excellent. So overall, in total, 477 individuals completed the entire survey. 64% were not white, 71% were under the age of 45, less than half had a 4-year degree, and 3/4 made less than $50,000 a year. We did note differences across gender identity in terms of sexual orientation, education, and annual income. So our initial findings, we found that 62% of our sample reported that they had experienced at least 4 ACEs, with transgender individuals or gender diverse individuals more commonly reporting that they had experienced at least 4 adverse childhood experiences before the age of 18. More than 1/4 of our sample indicated that they experienced 6 or more ACEs. In terms of looking at the individual ACEs, what we noticed was that verbal abuse, emotional neglect, and physical neglect were common experiences for the entire sample. But we did note significant differences between cisgender and transgender individuals when it came to verbal abuse, emotional neglect, and physical neglect. In terms of quality of health, what we did was we wanted to understand what was the relationship between identifying as transgender and your physical health outcomes. And so when we had that in a model by itself, what we saw was there were differences. And then when we added in ACEs and these other demographic characteristics, we saw that there was no significant difference between cisgender and transgender individuals and their self-report quality of physical health. We did, however, note that there were differences in the full model. So that would be sociodemographics, their ACE score, as well as whether or not they identified as transgender or gender diverse. And we saw that individuals were twice as likely to report poor quality of mental health compared to cisgender individuals. So what does this tell us overall? I think one of the biggest takeaways from this project was that, we had a substantial number of individuals who were reporting at least 4 more ACEs compared to US adults. And so what that's telling us is a couple of things. One, it could be related to the fact that San Antonio, there's a huge wealth divide. Poverty is fairly high in San Antonio, and that there might be also something going on that's specific to both transgender and sexually diverse individuals. We also noted that this was one of the first studies to really look at these outcomes of or experiences of neglect, emotional and physical neglect. And so what we noted was that across the sample, the individuals this was a very common experience, especially for individuals who are transgender and gender diverse. And so the other thing that we were thinking in this as well was that while early adversity has long-lasting impacts, there's also something about being transgender that puts individuals' mental health at risk, right? There's trauma that they experience as adults, there's oppression that they experience throughout their lives. There's just the inequity that is our system puts individuals who are transgender and gender diverse in a position that makes mental health worse because of the way that they're mistreated. The other thing that we kind of took away from this project as well, that's sort of an ongoing discussion too, is that there's likely specific adverse childhood experiences that LGBTQ youth experience. Some of those things include religious trauma, hearing or seeing another LGBTQ person being physically harmed, and then also like bullying in school. And I'll talk a little bit about this in the next couple of slides, but we are also trying to validate a measure that's looking at specific adverse childhood experiences for this population that were pulled from the 82 interviews that we did. The other thing that we need to be very cautious about in this type of work is that we don't just focus on the negative experiences that marginalized populations go through, and that we also start to identify positive childhood experiences or positive experiences as well, and what's the impact that that has on their health. And there's been some initial work done by folks at Johns Hopkins University to really think about these things, that it may be that you had some problematic household, but there was an adult in your neighborhood who supported you and allowed you to thrive in different ways that balances out sort of the negative experiences that you've had. So future directions for this work is as I said, we're currently in the process of developing and testing a sexual and gender minority specific adverse childhood experiences scale. And the second piece of this, because of the way that the measure is designed, it asks yes or no questions. And a lot of the folks on our community advisory board wanted to know, well, does it matter how much you're traumatized? Like, for instance, if you experience emotional neglect, is it different if you experience that once versus you experience that on a regular basis? And so right now we're trying to look, we have a paper under review that's considering those questions. So we bring all this information back to our community advisory board and say, hey, there's lots of trauma, but you already knew that. So the next question became, well, what do we do about this? And that's part of the CVPR process as well, is engaging with your community advisory board or with your community to figure out what are the solutions. One of the things that we're trying to do is tailor what's called cognitive processing therapy. It's one of the only treatments that's evidence-based for post-traumatic stress disorder, and tailoring that to meet the needs of sexual and gender minority individuals, and also delivered in spaces that are more accessible to these communities as well. The second thing that started coming out of our community advisory board was this notion of storytelling, and how can we work with elders in the community to retell their stories in a frame that's focused on resilience, and tell these stories and connect to youth within that same community. And so we're seeking out funding to do those things. So that's a short, brief sort of discussion about the research that we've done and some of the next steps that we're taking with our community advisory board. And I'm happy to answer questions about how we engaged with the community in more in depth than what I was able to discuss in this short presentation, but thank you.
Thank you so much. Does anyone have any questions for him? Well, awesome. Thank you so much. That's super interesting research. And I also think it's super important to highlight positive aspects of health and like mental health and just growing up. And I want to pass it on to the next presenter, which is Priscilla Hale. Thank you so much for being here. And if you could speak on the programming and what ALGO does, that would be amazing. Thank you.
My light just went out, so I think I look like you can see me still. So I was like, oh, the light just went out over there. So here we are recording. So thank you, Philip, for sharing all of that great information, much needed, as there's often little done, for our communities around what we need. And so for I have no screen to share because this is how I roll, is like I'm directly want to talk to the people. So I expected many of you who are going to be watching this or recording to be here to engage with us, and I could feel that energy, but I will act as if you the ones of you who are here are the students, and I'm speaking directly to social work folks. So we'll just roll with that because that's how I would do it, just roll with it. So ALGO's 35 years old. We just celebrated our anniversary this week. And so we do social justice, cultural arts, thank you, health and wellness programming. And so when I kind of did my presentation thinking about, as a young social worker, as a person thinking about, well, what can you do with a social work degree? None of what I'm doing, I ever imagined that I would be doing as part of my social work, right? Because in school, there's a lot of very narrowed ideas about what one can do with a social work degree, right? And often we get pegged as folks who are generally working in child protective services and going in and taking people's children and doing that type of thing, which I never did. So it's great to kind of just think about the trajectory of what is possible with a social work degree, but also thinking about how to engage with folks in communities around, developing and creating programming. And and so I came into an organization that has always been responsive to the needs of community. And the way they have done that is to directly ask the community, what is it that you are needing? What is happening now? And even when there has been grant funding or funds that have been specified for very specific events or activities, I would say, to address folks' health and wellness, or even cultural programming that we do, we've been able to be flexible in that, to be able to shift, not only able to, but willing to shift at any given moment as to what's happening in our communities. And we've been very intentional about that because we feel like it's the best way. That thing, build it and they will come. Well, some of us know you build it and they are not going to come, and they don't come. And then we're like, well, what's wrong with them? Why aren't they showing up? And the question for me has always been, what did we do to not make, what are we doing, or what can we do better to make sure that what we're doing is being responsive to community needs, right? Because, I mean, a lot of folks, it's very blaming, it's very looking at the individual, not looking at what we as organizations can do, as community groups can do to shift that, to be responsive. And a lot of that has come out of, we've been very flexible with our funding, so ensuring that we oftentimes only acquire funds specifically since 2006, that allows us to be flexible, but also allows us to do the work in a way that actually can make change in our communities, right? Too much of the funding is very much like, this is the way to do it, and this is what's gonna happen. And as we can see, particularly with HIV and AIDS, the numbers have not come down at all. And so our point was, well, we can keep doing what we've been doing all these years and be a part of that, or we can say there needs to be something different, right? And so one of the things we did in 2006 was we gave up all of our funding. There may be a different story out in this community, but the real story and the true story is that in 2006, we gave up 90% of our funding because we felt like it was keeping us too much in a box and not being able to be responsive to our communities. Was it a leap? Absolutely, it was a leap. But what we also did was we went to our communities and asked for them to become supportive of the work that we were doing, to be able to be responsive, right? And so that meant asking people to sign up as sustainers, asking people to come in as volunteers in ways in which, in more in-depth ways, right? Because we know that as a grassroots organization, that's how we are able to respond to that. And so, yeah, we took a huge leap. Many people thought we would not be here after all these years, and we have been able to be here. But that was very significant in that we did it intentionally, right? But we planned for it. It was like a year process of planning and sitting down with individuals and folks who had funded, people who had been supportive of that, to then develop. And so we did a lot of work for a couple of years with no funding, basically hardly any funding at all. But we still did a lot of work. So people didn't know that we were not doing it with any government funding or anything like that, but it allowed us to do and be responsive. And so, when I think about our current health and wellness program, it is supported and funded by the city of Austin. However, we acquired those funds and went after those funds because it was a more holistic opportunity for funding, right? It wasn't just focusing on one aspect of individual lives, because we know queer people and queer people of color, the lives are they're so vast. And so if you only focus on and address one area, then you miss out on all of this, and the work that you're doing doesn't work, right? It does not work. And so we were like, can we take people whole and complete and address everything that people are coming with? And that means your emotional, your spiritual, your whole being, as a way to get to a different point. Because we know that if those things aren't in place, if we don't address that, then we're acting like people are siloed, right? And the interventions and whatever you create doesn't work, and people get tired of hearing about the same old things. And where Philip's talking about talked about not just focusing on the negative aspects, we incorporate that in our wellness, like, right? It's health and wellness. And so when we know the obstacles of accessing care are there, we can also ask people to talk about, well, what ways have you been able to access care? What has helped? And if there aren't those examples that people themselves come with, we ask other people who have those experiences, who have good experiences, to share those, because we also believe that our community folks have a wealth of experience and skill base that we want to share with each other, that I'm not sitting here as the ED, as the expert and the one who has all the information. We absolutely believe that our community folks have skills, and so therefore we uplift them, and we have a platform, so let's make it available to them, right? Let's say, you know what, I know you have had experience doing this. How can you come in and share that with our communities around how did you access the care? What has happened? In all kinds of ways, right? And so I think when I think about just developing programming, I mean, we often do surveys with our community, like at the beginning of the year or throughout the year, to say, okay, what is happening now in your lives? What are obstacles that are now, because, you know, the funding we got is the same funding we've had for several years, but that doesn't mean we're going to do the same thing. It's like, what do we need? What are the discussions? What are the things that we need to be doing to bring folks in, but also to address whatever health needs they have, but also just to address like the cultural arts need. Who would you like to see as an artist? What would you like to see? Are you trying to make money as an artist, particularly now as a lot of folks are struggling? So can we do some workshops with working artists who are who are able to make a living continuously now? What skills can they share with our communities to say, look, this is something I have been doing, you know, virtually, this hasn't worked, this has, you know, kind of thing, to like give people, because a lot of people lost a lot of income. I mean, Austin is full of artists, right, that are making their living doing art, and there's not a lot of opportunity to do that. So we've created some spaces for that. You know, we immediately, particularly in these times, we immediately went into, let's talk to our communities, let's bring them together. We know that isolation is huge for our communities on the day-to-day over all the years. And so we do know that going virtually left out many of our community members. And so we tried to figure out, well, how can we also address that, right? But in this time of not being able to come together, we realized that's a huge gap, that people who are living with folks who don't have access to privacy, right? Because we've gone virtually, but let's just say I didn't have this space to gather right now, right? To be able to talk about, as a queer person of color, like, because my mama's over there and she don't know I'm queer, right? So how I'm now gonna have this conversation, either about telehealth or just about, I need to get tested, I need to get this, like, where I'm gonna do that at, right? I'm gonna do it in the yard over there with Ashwell, right? So like many of those things we've had to take into account, like, what does that look like? How can we take care of our people virtually? And shifting. So we are continuously doing that. And we did a huge shift with our programming in March. Many of our folks didn't have food. They did not have money. And so we, as part of our coalition, got together and raised over $100,000 and gave out direct funds to people because the city was being slow in responding. So we gave out mutual aid, no questions asked, other than, you know, we had a form, we created something, and we decided on how much money an individual person would get versus family. We're still doing that. We're still raising money to do that. I think now we're probably over $160-something thousand that the coalition has raised and has given all of that money directly out to community folks. And in addition to that, we did a lot of things around addressing people's food insecurities. And so there was a lot of vegetables being given to us. I set up a whole thing outside of my front door at my house. There was a table, but that's also where people came and got the mutual aid. They came to my house to get the mutual aid, and they also came there where we had vegetables, we had PPE, we got face masks donated, we got face shields donated, and we're still giving out those things, right? Like, so we created this internal to be external resource list about this is what not only we have, but we're canvassing all that is available for folks in Austin, but across the state as well, to address people's needs, because we know also that it's going, people's needs are increasing, particularly with the last cut in unemployment benefits for those who even had access to that. And so we're like, how can we gear up to move into the winter season? But we also know that the winter, are y'all getting rained on? We know that the winter season is going to bring on additional challenges for folks. A lot of that around increased isolation. So those who would want to get with their families, or who would utilize their friends and their families of choice, they're not going to have those options to do that. And so we're preparing and looking at how can we address those things as an organization in any kind of way, but also give people tools and skills. And so we've gone after funding and things like that that would allow us to be able to address those kinds of things as we come up into winter, and knowing that 2021, we don't know what's going to happen in 2021, right? And so there's a lot of pre-thinking happening so that we're not reacting, we're trying to be very proactive so that we're not trying to catch up. And, you know, as a Queer People of Color organization, we've been through some stuff. we have examples. We know what it's like to live through an epidemic and pandemic, because the organization ALGO started early on of wanting to be a social space. The AIDS epidemic happened, and ALGO shifted immediately into providing resources and care for people living with HIV and AIDS. And that was out of direct response to many of our community members and folks being directly impacted by that, and not having access to care and our spaces, particularly as there was a lot of monolingual Spanish-speaking folks, but also people who, there was a lot of Latinos that did not have access to care that was culturally responsive around their needs. And so we are using that history and that knowledge to build upon as we move forward. So I think that's enough. If anybody has questions or like to say anything. So.
Well, thank you. I know it's hard, especially right now, to like shift and pivot to meet the needs, because there's so many needs right now, but I'm so thankful to hear that you are doing so much to help people in the gender and sexual diverse community with giving food insecurity and payments. That's amazing. So thank you for doing that. And I am so excited to introduce our next presenter, Dr. McDaniel. She's going to talk about the Gen Equity study that she did.
Let me figure out how to share just the, okay. Share. All right, what can you see? All right, I'm just gonna give just a little background of myself as somebody who's still like kind of fresh out of being a student and who will always be a student, as well as a project that I'm working with, Gen Equity, and kind of what I'm hoping to do as next steps with Gen Equity. So overview, background, Gen Equity, and the next steps. My background is in public health. I got my BA in health sciences from Rice University in 2010. And I went forward to get my master's in public health and my doctorate in public health. I was a postdoctoral research fellow, NIH 232 from 2018 to 2020 at the Steve Hicks School of Social Work. And that specific postdoc was really around cardiovascular disease inequities. And right now I'm a Latino Research Institute fellow. And the reason I'm here today is to talk about my research interests in more so Gen Equity. So My main research interest, the reason why I got into public health is food security. I grew up on the east side here in Austin, and it was so obvious. My neighbors, people that were around me did not have access to healthy food. And also that interest kind of grew into just basic needs interest. So water, food, shelter, clothing, and then what people consider kind of like the really basic needs also includes education and healthcare. So the reason I kind of got into water and food, kind of just different times in my life during my doctorate program, kind of getting more involved with kind of the fracking research that was going on in South Texas, and that was really affecting Latino communities in South Texas, and what did they feel about their water wells not being secure any longer. And then food now, as well as shelter. And Gen Equity is more in the education space, but I'm also interested in healthcare access. And in all of this, I'm really interested in intervention mapping. So what can we do to make something that's more sustainable? I consider kind of digital interventions more sustainable, but maybe not. But how can we kind of create structural interventions that really attack and really meet the basic needs of all individuals, especially individuals with multiple non-dominant social identities. So Gen Equity is a project I got involved with at my time at the School of Social Work. And the principal investigator is Esther Calzada, and me and my I guess my partner in crime, Lady Savellano, she's a doctoral student at the Steve Hicks School of Social Work. We kind of started talking about what is really lacking in what's in studies of higher education, like what's going on for students that have multiple marginalized identities. And Lainey and I are kind of talking about ourselves. So like how do we navigate this space? How do we become who we are, and kind of exploring how educational experiences are different for people who hold multiple non-dominant social identities. So the methods, it was during summer and fall of 2019, we held multiple focus groups. Some were just a few people, some I think we're up to 12 students. And the focus groups were about an hour and a half to 2 hours long. And it was my first time really getting it, I've done a few focus groups, kind of more like an evaluation type, but this is just sitting down and we're gonna talk about what are your needs, what's going on, what is your story, how did you come to realize your social identities, how did your social identities affect your educational choices, and in what ways do you feel like your education is being affected by your social identities, or what other people assume your social identities are. And we used a multi-level model of intersectionality by Anne-Marie Nunez. So kind of bringing into, and this is really based on more education literature, and she's an educational scholar, but kind of looking, of course, all of the different intersections and how those different institutions and environments affect who you are. Some people think intersectionality is just, oh, I have all these different all these different identities, so I'm intersectional. No, it's really how those systems affect you. Kind of getting down to who was in our study. So we had a lot of different people in our study, and a lot of people in the focus groups were mixed. We were trying to, first we're thinking like, well, maybe we'll have like a Latino focus group, we'll have a sexual and gender minority focus group, but then we decided to kind of just mix everything up. And honestly, it was hard to recruit at first for the study, and so we're kind of taking people in as they came, but in a way that built such beautiful community building on campus. So after each focus group, we were all using our pseudonyms and no one really knew each other's names, but afterwards everybody had their cell phone out, getting everybody's number, because these conversations were just so powerful and really life-changing for some individuals in our focus groups. And as you can see, a lot of, not a majority, but 46% of our focus group participants identified as queer or LGBTIA+. And I'm just kind of going into like one of our domains. So during during the focus groups, it was kind of based on more of a grounded theory. So we had the Nunez model of intersectionality. We have certain questions that we use, kind of seeing how was your time in K through 12 versus college, your social identities. And then we ended up pulling out so many different domains let me go back to this in case you want to look at this demographic characteristics. But we decided to kind of, from our study, we were able to identify themes such as othering was a huge theme in this study. So what is the effect of othering on students' educational experiences, as well as what does it feel like to feel like you belong in a school? And what does that look like? Another major theme was improving supports. It's kind of what I'm going to go into. But if you have any questions about any other themes, if you want to talk about what we found for othering, for example, please feel free to contact me. So improving supports, I'm just going to kind of just throw out a few quotes on improving supports, and they're kind of from different types of improving supports and kind of see where I'm coming from. But first, let me give it overall an assessment. So in general, and the frequencies are for the focus groups, not for individuals. Our major categories for improving supports was accessibility resources, as well as policy, post-college preparation, safety. And within the accessibility of resources, which from my background and my research interests, I'm very interested in this accessibility of resources. Mental health resources was definitely one of the #1 things that came up in almost all of the study groups, on the focus groups, as well as financial aid, LGBTQ plus resources, first generation resources to kind of how do you navigate the system, improving transportation, access to resources during breaks, such as food and toiletries, and resources for graduate students kind of came up as specific as well. And you can kind of see that the policy was very much about transparency and really building diversity at the school and what it felt like for students who held multiple non-dominant social identities and not seeing individuals who look like them in the classroom, either as teachers or as other students, and those situations of othering that may need to call for training in diversity and inclusion. As well as just the advising and transparency within the university. And let me take a step back. So this is focus groups at UT. Not all of the students were UT students, but a vast majority were. So here are a few of our quotes and kind of give an idea of what type of, and we call this domain improving supports versus like needs per se. We're trying to be kind of taking more of a positive, like we have supports there, but what can we do to improve them? So mental health, of course, came up. And this is just I can give you like a part of this quote. Something that I feel like they can improve is the CMHC services, the Center for Mental Health Center services. Yes, like I'm really glad that they've been useful to you. And she's talking to another person in the group. I tried to use them when I was a little like earlier in my college career, and they're very unhelpful. A lot of times, if you ever experienced with mental health issues in the past and have sought treatment for them, they don't help you. They say like, oh, sorry, we're a temporary service, so like good luck, which I think is very effing dangerous because like, I don't know, like obviously if I call a crisis line, I need assistance. So kind of thinking about this, so mental health was, again, a very big issue that came up in multiple focus groups. And to us kind of seeing this, we didn't know that certain students feel like they were not being served by the mental health center, for example. And what can we do to help that? And this is a whole other, another quote about mental health services on campus. I think it's better now. I've heard they've made improvements, but I don't like, especially whenever I was a freshman, they would have or like they would say they're unavailable, but they really would only do like suicide prevention, which kind of made me feel like worse. It's like, so you only care whenever there's like quantifiable evidence. So only when somebody kills themselves, like you only care about making the university look good. Okay, the CMHC doesn't really help. So these are students kind of talking about their frustrations with trying to access healthcare on campus. Another frustration that we found was just access to organizations on campus. So this is for an individual this quote is from an individual who identifies as transgender. Yeah, that's also sometimes why it's frustrating when it's a queer group that's like specifically just for gays and lesbians. Like they in theory include others that are focused on, because then it's like, not only are you going through the basic 101 stuff, you already know, they're also like not even talking about your identity. And sometimes like you bring it up and it's like people are just still kind of figuring it out, like that's too confusing. So kind of, we were able to also really identify what's going on even within student organizations. Now, what can we do about this? That's for next steps. And then as far as basic needs, one of our quotes would be really great if like during winter breaks and like Thanksgiving breaks, they provided vouchers for students who are staying over to get access for toiletries and food. So these are for students who don't have a family to go back to, who are on campus during times when everyone else is gone, and where do they go for resources? And why aren't there resources provided to them? So Gen Equity, I guess I was trying to frame it for this presentation as this is kind of our needs assessment. We're trying to figure out what's going on with the students. Yeah, we're going to definitely write a few papers about othering, about other issues that came up. But going into this project, I didn't think that we would be moving forward with doing some type of implementation plan or some type of program itself for students in Austin. But now it's seeming as though, and not seeming as though, it's definitely a goal of mine to move forward with this. So kind of giving an idea of what, yes, that wasn't necessarily the goal of the project, but that's what we're going to do. We're going to explore needs further, especially basic needs of healthcare, food. And with this evidence, this needs assessment, and also create a community student advisory group to really specify program goals. Again, going into it blind, we didn't know that the mental health services were going to be an issue that would come up during the focus groups, but that may be something that we need to focus on as a program. Or maybe it's on more food insecurity issues or more housing issues, especially in times of COVID right now, for students that are not in Austin and may be staying with many other individuals in their house and they do not feel safe. So just kind of figuring out what to do next. And that's what I kind of brought into kind of my intervention mapping. So to create an effective behavior or systems change intervention, taking into account theory, evidence, and community assessment. So the community assessment for this project was Gen Equity, and what we're going to do moving forward with, again, trying to focus on a program goal for students with multiple non-dominant social identities. And that's all I have.
Thank you, Dr. McDaniel. I really think it's important to highlight student experiences. I feel like a lot of students just feel like they can't speak up or say anything about the issues that they're facing within the school system in general and what the school offers them. I think they try to just take it as it is, but in reality, they can improve and they should improve because there are a lot of people who do need help out there. So thank you for doing that research. That's amazing. And I'm really excited to see what papers you put out. So thank you so much. And then finally, I wanted to introduce Ben Walker and his guests, which I would love for you to introduce, who are going to speak about Ashwell.
Absolutely. First, thank you to Sheridan and to Yona for having us. It's our pleasure to be here. Thank you to Drs. McDaniel and Schnars for giving us an update on their awesome research. Thank you for the great work you guys are doing. It's always an honor to hear from Priscilla, who is basically a living legend in the queer nonprofit community. So thank you, Priscilla, for being amazing and inspiring us every time we get to hear from you. But I have the honor of having Linda Serna with me, who is our intake coordinator for our case management division at Ashwell, and case manager now. So they also are one of the best resources for services in Austin that I'm aware of. So, and understands the university system more than myself. So feel free to jump in at any point of the Asheville conversation, and I'm sure they'll, after I talk about Asheville, tell me what I missed.
Oh, thank you for having us.
So one of the key themes that I picked up on listening to everyone so far is the theme of accessibility. So everything that we do at Asheville is based on how can we get this service to our clients. We are majority uninsured, 3/4 of our patients are uninsured, a majority Black and brown, 3/4 of our patients, over 3/4 of patients are identified as Black or Latinx clinic. So accessibility is super important. One of the main takeaways I've had from starting new programs is if you're trying to say that your service is for a marginalized population, you can't create barriers. You have to cut down whatever barrier is possible, and you can't have wait lists. You can't waitlist people who are marginalized all the time. If someone comes into your clinic or your program and you've told them this service is there for them, it better be there for them. Or else you've broken the trust that you've had. And when public health services are often advertised, we get excited and we say, hey, we have this thing for everybody. But oftentimes that ends up putting someone on a wait list, and then that kind of destroys a trust that this service is for someone that doesn't have insurance, or who themselves or their parents or grandparents haven't had access to a primary care provider. So at Asheville, all of our medical services are provided at no cost. That is, because we started with 3 core services. That was STI treatment and screening. That's gonorrhea, chlamydia, syphilis, HIV screening and treatment. And then we added additional services after those were solidified. So those are hepatitis C treatment, cure treatment, and gender care, including HRT. Did I miss anything so far?
Yeah,
So that's all offered at 0 cost. That means that we cover all the doctor's visit. We cover all the lab costs. And 99% of the time, we cover all of the costs of the medication. There's a few loopholes where people will fall into, usually people whose income is higher than is able to access resources that we might not be able to get fully paid medicines for. But even thinking about that, one of my primary concerns is figuring out how we can get free or lower cost medicine for all of our patients. Actually, that's a whole department that we have for that as our patient navigators. Their role is to make sure that once someone comes in and sees a provider, that they get connected with a pharmacy and whatever copay and deductible help that they need to get their meds. When you see doctors in private practice, and even doctors working in community systems, often think that once they prescribe a medication, it's magically going to get into their patient's body. It's not. There's transportation issues, there's a whole host of cost issues. Even people with insurance feel like insurance is just so inaccessible because of concepts like copays, deductibles, co-insurance. What's co-insurance? I didn't know until I had to work in co-insurance. But so we have these systems that are just so, are designed to make healthcare less accessible because it's a for-profit industry. So in the nonprofit context, especially a clinic like ours, we design it to make it as accessible as possible. So if someone is coming in, we want the only reason, if they didn't show up for their appointment, we want to know why. And then once we figure out the reason why, we want to see if we can help with that. So another thing we started is a transportation assistance program, where if a patient has difficulty getting to the clinic, we will call them a rideshare, and we will pay for it to get back and forth to the clinic. We'll do bus passes. We have access to do taxi vouchers. So part of our job is to make it as accessible as possible in the beginning, and then figure out where the deficits are and try to meet those. That's where maybe our esteemed academic colleagues here can help us out as well. So yeah, those are our general services. And then case management, right now it's for our HIV positive patients, but we have plans to expand that to hepatitis C patients and to PrEP patients. And a case manager provides more of a wraparound service for that patient. So it's either a patient that has higher medical need or a patient that has different needs that are impacting their treatment or their ability to access medical care. So they have someone working with them one-on-one on whatever issues in their life are causing them more challenges. So one thing that we've identified there is case managers historically have really only been a resource provided to, in sexual health, HIV positive people. HIV positive people are not the only people that have difficulty with their health, difficulty accessing the things that they need to stay healthy. So how do we provide services to people that we can't tap into Ryan White funding for? So that's one of the challenges that we're looking at right now. How do we fund this? And a lot of things that we do, pretty much most of the things that we do, we self-fund ourselves by identifying what the area it is that our patients need more help, and then trying to fund that ourselves, or find a partner that can work with us together. I know one of the other questions we were talking about is, how do you create services? And it's a valid question, because it's possible. It's possible. I'm living proof that you can create services. But sometimes it's hard. Sometimes it's very hard, but you can do it. So that's my overall message there. The keys to doing it are understanding what the landscape is, what's already there, understanding what you really want to accomplish, and then what can you contribute to it. So connecting, understanding what the landscape is so far. If you're trying to create something new, is what you're doing unique? Or would your best services, would it be best to help someone that's already doing that? In nonprofits, sometimes we have an issue of duplication of services, where people think, oh, I want to do this thing. Well, they want to create their own version of it, when oftentimes the community is better served with more people promoting existing services that are trying to get off the ground or trying to sustain themselves. And the other is just being a good community member, being a good partner, and seeing what we can do when we collaborate with each other, which is often a really powerful ability when we can do exactly what we're doing here, and make sure that we're connecting and understanding what's going on, what research is going on, how we can contribute funding to each other, how we can build better networks between our programs so that patients can get from point A to point B. That's one of the biggest issues with nonprofit landscape, especially in Austin, is the disconnection with a lot of our existing organizations and programs. And then physically trying to get patients from point A to point B. So those are my general thoughts. What do you think, Linda?
You covered a lot. Something I also wanted to kind of bring up, kind of connecting a lot of my work at UT was like realizing sort of resources and access to those, and how many different points of entry there are, and depending on your identity, how that can be very skewed to what you end up having access to. But at Asheville, I think one of the things that's really cool is like we are developing a lot of our programs in the case management, but we have a program called Bridge the Gap. So maybe for folks who don't qualify for being case manager with us, food insecurity, especially when we think about like folks that we're working with, food. So we have programs in place too. So if somebody comes and they're like, hey, after sort of figuring out where they are, so like the transportation's an issue, maybe it's like, ding, like what else could be an issue with this person? Like if they're maybe not making appointments. So we've been able to kind of have our own program called Bridge the Gap, and we can like build backpacks for folks. We can give them food if there's dietary restrictions, as long as they are in our care. So they don't have to be HIV positive, but just one of our clients. And so we're also building out programs kind of like that to support maybe folks who don't have access to other resources like the Ryan White funding. And there are other ways too that we're, funding comes from different places, but when the CARES packages came out, we've received funding, so we were able to assist folks, no matter if they were a client or not, or if they had ever been affiliated with Ashwell, and sort of help with those programs. So that's something that we're always looking for too, with other programs in addition to the services that we have in-house. Yeah.
I want to connect that to any of your background from working at the Center for Mental Health at the university.
Oh yeah, I was interested. I did work at UT, so a lot of those responses weren't new. So I also worked with the Voices Against Violence program at UT, and actually helped develop, as one of the 2 students who helped develop the IPVS, the Interpersonal Violence Peer Support Program. And part of the reason that was such a big issue is because the folks in my community, queer and trans people of color, I also did organizing with QT PACA, And I also did training in the Gender and Sexuality Center, like the ally trainings. So realizing that all the communities that I was in and my friends and just people I was listening to, both graduate and undergraduate, sort of their experiences with the lack of resources and or the barriers, whether or not like they didn't know how to navigate the system. It was the first time they were, they've already had bad experiences. Maybe their professors weren't supportive. They didn't have enough food that day to have energy to go. One of my communities at the time was being homeless on campus. So that like I was in a whole nother world of like queer and trans folks who were homeless. And sort of getting access to like, okay, do you go to Dean of Students? Do you go to Student Emergency Services? Do you need to start at CMHC? Do you actually need to start at the student? Some folks building like relationships in university health system, like with Dr. Bloomer. Ginger Bloomer was a really amazing ally and was like, okay, like if we can get you here, then from here, like where do we go? So yeah, trying to take that work of the person who's looking for those resources to having to navigate all of that. So I'm really interested in your work. And again, all of that with the sort of interpersonal violence, also thinking back to those ACEs scores, and then what does it look like for somebody who has a score of 4 to like 10 coming to college for the first time and sort of learning to understand that in a new way, where this might be the first time they're out, or, so did that kind of, yeah, so did a lot of work at the university and navigating those systems. So my hope was too, like in Asheville, being connected with that system. So when students feel like they don't get what they need necessarily at UT, Asheville is a place they can come and maybe get some of those resources as well.
When Nina was speaking, I remembered 2 other things. The programs that we're developing at the moment, one is a behavioral health program, which is we're trying to address some unmet need there. And then also we're working on an Asheville harm reduction program with syringe exchange and harm reduction supplies. So we're doing our best to try to hit unmet needs where we're seeing them. But of course, we can be better informed by people doing research in our communities as well.
Thank you. With all the presentations, I definitely see the need to listen to community voices and listen to lived experiences. I think that's extremely important when developing programming and also doing research. I think, listening to voices is just, and amplifying them is really important. And I also want to point out, these systems are so difficult to navigate. So it is so nice to be able to share resources in any way we can, like this, or, even through the Pride pop-up is just an amazing way to do that. So I hope out of this that some people will learn more about resources that are happening in the community or are interested in what y'all are working on, and maybe sparks them to kind of imagine their future doing something like this, because, we always can use more people wanting to advocate for the LGBTQI community. So I just wanted to thank y'all for being here. And I wanted to do a discussion with students, but I think students will get a lot out of what y'all have been talking about, especially with amplifying community voices, and also how you're shifting programming to fit in with the times, especially, thinking about privacy, especially during COVID, and also transportation as well. I love that you guys provide free transportation and also free health services as well, because I know so many people have had to jump through insurance hurdles, even with insurance, and people who are uninsured that are having difficulty getting that. And so, I just wanted to thank y'all for speaking. Yona, do you have anything you'd like to add?
No, I think this was such an illuminating conversation. All of y'all presentations were so illuminating, and I just want to thank y'all for sharing your expertise and your experiences. And yeah, just to echo what Sheridan said, it totally seems like the essential pillar of both research and community involvement, organizational grassroots movements within Austin and throughout Texas, is this idea of bringing in community and having narratives be at the forefront of all of our work. And it seems like y'all embody that in everything that you're doing. I would love to ask y'all if you have any extra time that you'd love to share, if any of you guys have advice for up and coming undergraduates or graduate students who are thinking about a career in public health, who are thinking about a career in healthcare in general or social work. If you have any advice for them, we'd love to hear it.
We do take Practicum students. So if you're looking for an internship, we have limited availability, but we can work with students. Highly recommend getting that experience.
I guess I second that. Take chances with what you experience. So maybe get involved with the organization or get involved with the internship. You're like, oh, I may not necessarily be all the way interested in that. And you kind of just see make your mind just not blow your own mind, but still like try to really take risks in order to learn more about other people's experiences. And you may find another whole career path for yourself.
And I think I would say, I think the thing that helped me when I was looking for employment was that my resume of the folks I had worked with was vast. Like I had worked in numerous organizations doing volunteer work, not worked, but doing volunteer work, doing multiple internships. And so a lot of that gave me a lot of much needed experience. But I also had a job very early on that was not related to social work, that where I had a lot of responsibilities and I was very young. And so I think that painted a picture of my level of maturity about what I was, my ability to be responsible, even if I didn't have some of the skills. I mean, I can tell you when I got the job at Algo as a case manager in 1998, I did not know a thing about HIV. I barely even knew how it was really contracted. I did do some research, but what I could also present was my ability and willingness to learn. But I came with some of the stuff that is not, some of the skills that you can't teach folks. And that means I can get with community. I come from community. I understand communities. And oftentimes those are the things that it's like, well, I could teach you how to do that report. I could teach you how to do this, but I can't teach you the interpersonal things. And so I would definitely say, you know, the more you engage and interact with folks across spectrums, that will definitely be something that will boost your skills, but also you know, make you more presentable to folks who are looking in to bring people into their spaces. So.
I would just somewhat echo what Marisol said around don't be scared to fail and own your mistakes as much as you own your successes. I know that in my career, I've made several mistakes several times, and it's about figuring out how to take ownership of those mistakes and learning from them and then trying to do better the next time. So don't be scared to fail. Don't be scared to not always do your best. You can do, you know, but continue to grow and continue to learn from your mistakes.
And I just want to add that there's so many ways to get involved in the community. I know right now with COVID, it's kind of difficult, but everyone I've spoken to who was interested in this research and in this community have been so accepting and kind and understanding and able to let me research, help with their research or learn more about their programs, and they're very open to speaking on that with anyone. So if students are interested, you know, try to reach out. I mean, it might take a while for a response sometimes, or, you know, you might have to call people, but it doesn't matter, because if you are, if you are really interested, they can, like, people who are in this field can give you a lot. and they can help you a lot. So thank you guys for being here. I really, really appreciate it.
Thank you to you and Yona. This was fun. Thanks for having me.
Thank you for having
Everybody
us.
else for the great presentation.
Thank you.
Um,